Dean of the Nell Hudson Woodruff School of Nursing at Emory University and the co-chair of the Committee on Implementing High Quality Primary Care. And it's my pleasure to welcome you to our third installment of our Tuesday midday webinars on different components of this report. Every Tuesday this month, we've been diving into a different theme of the new National Academies report. And we're so glad to have you with us. And today we're going to be doing a deep dive into the future of the primary care workforce and how to best prepare individuals to deliver high quality primary care. And I'm joined by a simply fantastic group of committee members and panelists that I'll introduce you to in a moment. After the introductions, we're going to have a brief presentation summarizing the report content related to workforce and training. And then we're going to move into a discussion with our panelists. And then to close out the meeting, we're going to take questions from the audience and respond to as many as we can. And so I encourage you to use the question and answer function of the Zoom chat to put your questions there. A recording of the event and the slides that we present today will be available online after the event concludes. So in addition to myself, joining me today is Tumani Coker, and Tumani's joining us from the West Coast, where she is Division Chief in General Pediatrics and Associate Professor of Pediatrics at the University of Washington School of Medicine and Seattle Children's Hospital. Brenda Weiss-Brennan is with us today from Utah, where she is the Director of Mental Health Integration at Intermountain Healthcare. And Mary Roth McClurg rounds out our committee participants, and she is a professor and executive vice dean and chief academic officer at the University of North Carolina Ashelman School of Pharmacy. In addition to our committee participants, our invited panel today includes Candace Chen, who is an associate professor in the Fitzmullen Institute for Health Workforce Equity at George Washington University. Dr. Chen was previously the director of the Division of Medicine and Dentistry at HRSA, the Health Resources and Services Administration, where she led programs to enhance training in primary care, oral health, and geriatrics. Joining Candace is Carolyn Clancy, who is the acting Deputy Secretary of Veteran Affairs, and previously Dr. Clancy served as Assistant Undersecretary for Health for Discovery, Education, and Affiliate Networks in the Veteran Health Administration. She was the Deputy Undersecretary for Health for Organizational Excellence and the Director of the Agency for Healthcare Research and Quality. Tracy Salt is with us also from the U.S. Department of Veteran Affairs, where she is Director of the Primary Care Clinician Services in the Office of Primary Care. And Deb Troutman is our final panelist, and she's the President and Chief Executive Officer of the American Association of Colleges of Nursing, as well as the Chair of the Interprofessional Education Collaborative. Previously, she was the Executive Director of the Center for Health Policy and Healthcare Transformation at Johns Hopkins Hospital. So quite an outstanding panel and participants from the committee with us today. And now I want to turn the presentation over to Dr. McClurg, who will give us the background of how the committee approached the workforce challenges in primary care. Mary?
Thank you so much, Linda. It's my pleasure to share highlights from the chapter on the future workforce. Next slide, please. This slide depicts the committee members that comprised the Committee on Delivering High Quality Primary Care. I won't read through all of the names, but we were well represented by a number of disciplines, a lot of diversity, adult medicine, nursing, pediatrics, health economists, family medicine, social sciences, pharmacy, PAs, dentistry, community health workers, lots of representation. And we were led by just our wonderful co-chairs, Dr. Linda McCauley and Dr. Bob Phillips. Next slide, please. Our statement of task was to examine the current state of primary care in the United States and specifically develop an implementation plan, which was unique to this report. The goal was to build upon the recommendations from the 1996 IOM report, Primary Care, America's Health in a New Era, to also strengthen primary care services in the United States, especially for underserved areas and populations, and to inform primary care systems around the world.
The cap is on.
One of the important components, or some of the important components of the implementation plan that we had to consider and that are exemplified in this report, we do talk a lot about barriers to and enablers of innovation. We talk about addressing the needs of individuals, families, and communities, population health outcomes. Team-based interprofessional care is key to the report. We also discuss in one of the chapters technology and other technological innovations, changes in the workforce, the care delivery and payment models, improving the quality of care and the importance of meaningful measurement, primary care needs of different populations with a particular interest in underserved and rural areas. And then we do address behavioral and social determinants of health as well in this report. Next slide, please. We do have an updated definition of primary care stemming from the original definition in 1996. And this definition suggests that states that high quality primary care is the provision of whole person integrated, accessible, and equitable health care by interprofessional teams that are accountable for addressing the majority of an individual's health and wellness needs across settings and through sustained relationships with patients, families, and communities. I wanted to highlight a few things about this definition and some of the shifts from 1996 that we considered in writing this definition. First, there's been a significant shift from the provision of services to integrated whole person health, and you'll see that reflected in this definition. There is a foundational, sustained emphasis on relationships with patients, families, and communities that is at the core of this definition. The importance of communities and their roles in the provision of high-quality primary care are reflected here. The need for care to be equitable. Interprofessional care teams are also core to this report, and you'll see that illustrated throughout the workforce chapter. And then obviously the diversity of settings and the modalities used to deliver primary care are some of the shifts that have occurred that are reflected in this new definition as well. Next slide, please. So primary care is a common good. We believe that primary care has high societal value among healthcare services, yet is in a precarious state, requires public policy for oversight and monitoring, and primary care as a common good needs strong advocacy, organized leadership, and public awareness. The committee believes strongly that because of its societal value, that it is designed for everyone to use throughout their lives, primary care deserves to be treated as a common good. And so a lot of time and attention was given to primary care as a common good in this report. The committee believes its implementation plan will elevate primary care to the common good status that it deserves and that this country needs. Next slide, please. The report has 5 objectives for achieving high quality care. The first is to pay for primary care teams to care for people, not doctors to deliver services. 2, access, to ensure that high quality primary care is available to every individual and family in every community. The third objective is workforce, to train primary care teams where people live and work. We also focus on digital health as a need for achieving high-quality primary care, and that is to design information technology that serves the patient, family, and the interprofessional care team. And the fifth objective is accountability. We must ensure that high-quality primary care is implemented in the United States and that much good comes from the report. Next slide, please. So creating a structure to support team-based integrated care is really described very well in the integrated care and workforce chapters of the report. This slide really suggests that everything hinges on the communities and the patients and the structural supports that do support the interprofessional care team. We start by looking at the health needs of our patient populations and communities, and taking that and coupling it with the existing services that exist in our local communities and populations, the healthcare services, the community-based resources, and taking those together, that should really inform the development of our team, our interprofessional care team. At its core, we always have the patient, the primary care clinician, and a medical assistant or nurse. But we also have, importantly, an extended community care team, which may be various community care agencies throughout the community, our school systems, our aging and disabled services. But we also have extended health care team members that will comprise the interprofessional care team. This could be our dentists, our community health workers, pharmacists, and so on. And then our interprofessional care team is supported by governance in primary care or the practice, by financing, and appropriately by health IT. So there's a lot more that's described in the narrative of the report about creating this structure to support integrated team-based care. Next slide, please. In the previous slide, I talked a bit about the interprofessional primary care team being comprised of the core team that you can see depicted here in purple. The core team, as the report suggests, may also include members of the extended healthcare team, but again, it depends on the needs of the population and who is available within the local community. So there may be times where your core team is comprised of the individuals you see here in the purple, along with a social worker or along with a community health worker. But the extended healthcare team, and again, these are just examples. We go through many more types of interprofessional primary care team members. They're too exhaustive to include on this schematic. But extended healthcare team members may be behavioral health specialists, social workers, early childhood specialists, care managers, pharmacists, and so on. And then in orange, we illustrate the extended community care team members, home health aides, social support services, school-based services, aging, health behavior support services, and so on. So this again is described extensively in the workforce chapter and in the report on designing high-quality interprofessional care teams. But again, the important point here is that the team is designed and based on the needs of the population and the resources available in the community. Next slide, please. The primary care workforce today, a few facts to share. A greater density of primary care physicians is associated with increased life expectancy. We see this as evidenced in the literature. On average, about a quarter of medical education trainees, physicians in particular, do go on to primary care, but less than 8% go to rural practice. Non-white professionals are underrepresented in nearly every clinical healthcare occupation, and that's described in much greater detail within the report. And most primary care training currently is occurring in hospitals. Next slide, please. Integrated primary care delivery, I talked a bit about this in an earlier slide, but this is relational provision of whole person care that produces the person, family, and community health and well-being. It relies on interprofessional teams and payment models that support the team. And then the largest body of evidence that the report describes currently that supports behavioral health integration, or the largest body of evidence supports behavioral health integration for child and adult populations. And Brenda will be talking a little bit more today about her experience within Intermountain Healthcare with respect to the good work they're doing in true integration of primary care delivery. Next slide, please. So the workforce chapter is really focused on the objective of training primary care teams where people live and work. Next slide, please. This report shares 2 action items. I'll walk through these 2 and I'll share a bit more detail about each of them. First, the first action, healthcare organizations should strive to diversify the primary care workforce and customize teams to meet the needs of the populations they serve. Government agencies should expand educational pipeline models and improve economic incentives. Within this particular action, we do have 4 subcomponents that we do elaborate on in greater detail. The first is that public and private healthcare organizations should ensure the inclusion, support, and training for family caregivers, community health workers, and other informal care team members. The Department of Education and HHS should partner to expand educational pipeline models that would encourage and increase opportunities for students underrepresented in health professions. HRSA, state and local government and healthcare systems should redesign and implement economic incentives, including such things as loan forgiveness and salary supplements, to ensure that interprofessional care team members, especially those who reflect the needs of the community, are encouraged to enter primary care in rural and underserved areas. And finally, that health systems and organizations should develop a data-driven approach to customizing interprofessional teams to meet the needs of the populations they are serving. And Brenda may talk a bit more about this. Action 3.2, CMS, the Department of Veteran Affairs, HRSA, and states should redeploy or augment Title VII, Title VIII, and GME funding to support interprofessional training in community-based primary care practice environments. We do talk a little bit more about HRSA funding, specifically Title VII and Title VIII programs. And for other health profession trainings, we should look at increasing this and prioritizing interprofessional education. HHS, enabled by Congress, should redesign the graduate medical education GME payment to support the training of primary care clinicians in community settings and populations, particularly in rural and underserved areas. And finally, GME funding should be modified to support the training of all members of the interprofessional primary care team, especially if we are to look at the patients in the interprofessional care team as at the core and at the heart of delivering high quality primary care. More support is needed for the team. Next slide, please. In summary, the primary care physicians currently lack diversity and train in hospitals and academic health centers. We need to move this more into communities in rural and underserved areas and meet patients where they are. We must prioritize the diversification of the primary care workforce, include, train, and support important members of the team, such as family caregivers, community health workers, and other team members. HHS and DOED should expand the educational pipeline models. We do talk a little bit more about the role of HHS and the Department of Education in the education and training of primary care clinicians and other team members in the report. And then we need to train diverse team members in the community settings that they will serve. Getting them into community settings, especially rural and underserved settings, will really serve patients in primary care well. So redeploying or augmenting funding, including HRSA and GME funding. Next slide, please. At this time, I'd like to turn it over to my colleagues, Tamani Coker and Brenda Rice-Brennan. Tamani will talk a little bit more about payment and for integrated interprofessional care teams. And then Brenda will share more insight into Intermountain Healthcare best practices as it relates to integrated primary care and the delivery of primary care using interprofessional care teams. Tamani and Brenda.
Thank you, Mary, and thank you everyone for being here this morning. So Mary did an excellent job of really explaining with those schematics what an interprofessional primary care team can look like, and really how that team is the foundation of high quality primary care. Now that foundation allows us to be able to provide team-based integrated care. And this kind of team can make it possible in primary care that we can actually address the multiple needs that patients and families in low resource communities have. And this is how we achieve health equity in primary care. But to do this, we have to have an interprofessional care team, as well as the key community partnerships that we need to provide that care. For me, as a practicing primary care pediatrician and a primary care researcher, I partner with community health clinics to implement community engaged models for providing preventive care services for families in low-income communities with young children. And these models use elements of this interprofessional care team, so non-clinicians as part of the team. In one of these, we use a bilingual bicultural health coaches for parents. These are called parent coaches, who have become an important part of the child preventive healthcare team at these partner community clinics. And I want to share a story with you about how important it can be to have that interprofessional care team for families. About midway through the start of the pandemic, a mother who came in at one of these clinical sites right here in near Seattle in Tacoma for her infant's newborn visit was lost to follow-up. And so she didn't return for her infant's subsequent baby visits. Now, these visits are really important to ensure that the mom and child have all of their social, health, and developmental needs addressed. And so that first few months of infancy can be a very difficult place for mom and baby, as those of you with children on the call know. Now, in this case, the mom showed up at the clinic just a few months later, after that first newborn visit, asking for one of our parent coaches at one of these clinics. And her name is Rosa, and the coach. And so that's the clinic's parent coach. The mom told the front desk staff as she arrived, she didn't have an appointment, that she wanted to talk to Rosa because she lost her apartment and didn't have any place for her and her baby to live. And that's where they were currently sleeping on the couch at a friend's place. Now, that mom built such an important relationship with the parent coach that when she really needed help, she came looking for the coach. She also understood the role of the coach in the full interprofessional care team, that the coach's role was perhaps a little bit different than the clinician's role, than the role of the person who provides, let's say, the lactation consultant or the nutritionist or the medical assistant. This is the type of primary care that we want families to have, a relationship-based care team that has members of the team who are experts in all of the things that our patients and families need. Now, most clinical settings don't have a parent coach or a health coach or a community health worker or really anyone else on that interprofessional care team other than the primary care provider. And that's because that's not who gets paid in primary care. So we really had to think about how can we pay for this interprofessional care team to allow us to provide the high quality whole person integrated care that Mary was talking about in those slides. So the committee made some recommendations for payment, and those recommendations really go hand in hand with the recommendations that Mary just discussed for workforce. So the overall objective under payment is to pay for primary care teams to care for people, not doctors to deliver services. Now, the committee broadly recommends a multi-payer shift away from fee-for-service as being the default payment model. We recommend the use of hybrid models, part fee-for-service and part capitation, where fee-for-service is used in the case of services we want to encourage as clinicians gain experience with the model. The payment model needs to be consistent across payers to motivate change and to simplify the reimbursement environment. So the primary care payment model should have the following characteristics. First, it needs to pay prospectively for interprofessional, integrated, team-based care that includes incentives for incorporating non-clinician team members and for partnerships with community-based organization. And that allows us to provide the kind of care that we know that families and patients need. The second one is to be risk adjusted for medical and social complexity. Third, to allow for investment in team development, practice transformation and infrastructure, because we can't go from where we are now to that schematic that Mary showed without really having investment in order to be able to develop and design that. And then lastly, we need to align incentives to measure and improve outcomes. The committee also recommended that for larger providers who are already engaged in population-based risk-bearing contracts between a delivery system and the payer, such as ACOs, the payer should ensure that sufficient resources and incentives in those systems flow to primary care. So those are just a real high-level version of the kind of payment recommendations that the committee made that go truly hand in hand with those workforce recommendations, and that we need to be able to provide the interprofessional, team-based integrated care that Mary's talking about. And then I think Brenda's gonna give us some really on the ground ideas about what that integrated care looks like next.
Thanks, Tamani, and thanks, Mary, and thank you, Linda, for the introductions. I am the principal investigator currently at Intermountain for integrated team-based care, but I've spent the last 4 decades as a psychiatric nurse practitioner and medical anthropologist, providing, studying, and designing the implementation of integrated team-based care. And I have been dedicated to normalizing for patients and families and the staff that care for them, the connected experience of valued whole person care. So I wanted to underline that. But I'd like to make an opening reflection from our patient and family advocate from last week's webinar that was discussing access and what patients and families really need. And she made this statement that really stopped me in my tracks about how do we really talk about workforce and how interrelated all the 5 different objectives are. She basically said there has to be a way to strongly align and connect patients and families to the resources they need to have good outcomes. And simply said, our report provides that way. Each of these 5 objectives are interrelated and connected and depend upon each other to move an implementation process forward. Well-designed interdisciplinary teams rooted in strong relationships are a major focus of this report, but they need strong alignment through our common good mission and our new definition of primary care centered around whole person care. Payment reform, which Tamani just talked about. Bi-directional empanelment, which means the patient and family are members of the team. And as Dr. Grigg said last week, empanelment to patients and families mean they know me. I'm part of the team. We also need to be able to connect the team resources through integrated care workflow processes that are matched with the population's complexity. And as Mary mentioned, this is discussed in Chapter 5, including social, dental, and public health integration. Coordinating with family and community networks. And well-designed teams need integrated interoperable technology so that we are able to be there for them at the right time, at the right place, and in the right language. And I say that broadly across, that we need to be able to culturally be sensitive to the language of how patients and families need to be cared for. But what I would like to focus on from Intermountain is our experience in producing positive outcomes over time. In order to produce and sustain effective levels of high-functioning teamwork, this requires leadership and accountability. This leadership and accountability normalizes and operationalizes and rewards integrated team-based care through data transparency and actionable self-study. There has to be a framework and a process by which you are consistently adapting the implementation plan and the needs of the workforce and the population. This then requires collective action, which one of our payers mentioned in the payment, that this is a collective action problem we have. We all need to be doing this together and not one pocket or group of people reaching outcomes, but then we can't actually do it for an entire community or a nation. So as you have this collective action and you organize it, it needs to be measured and scaled through an implementation process a scorecard, a measurement process that helps teams adapt and train through the process of learning how to work together and be a team. This requires linking cost and quality metrics to the clinical work processes that are connected to the data and that are connected to the technology. And this produces the return on investment and value over time, and strong relational networks in the community. So in closing, I think what I would like to share is that, yes, there is a large body of evidence that supports mental health integration and behavioral health integration in adult and pediatric populations. But it became apparent to me working with this committee for the last 18 months that even at Intermountain, with all the institutional and leadership support and being able to have an integrated delivery system and show outcomes and savings in a fee-for-service market, that it is very difficult to scale these innovations for everyone in this country without what's written in this report. These bright spots across the country that are addressing the social, racial, and mental health and economic disparities need to be available as a common good, as we state clearly in this report, is our social message that's driving and organizing each of the 5 objectives. But without accountability and coordination at the national level to ensure that an implementation plan for each of the 5 collective objectives is addressed, we will not be able to reach all of the folks. So I think this report gives us an opportunity to see how each of the 5 objectives, and we have next week and the week after to kind of pull the last 2 objectives together in terms of digital health and accountability, that will be really, really welcomed for the rest of our committee members. Thank you.
Thank you so much. As you can see, what a committee we had with such great representation, because the scope of the report is broad, but this is a very broad, multifaceted problem that our country is facing in the delivery of primary care. I'd like to start out with our moderated discussion and ask our colleagues from the VA, Dr. Clancy and Dr. Salt, to speak to us about what's happening at the VA to ensure a diverse workforce that looks like the population for whom they are caring. Dr. Clancy, do you have some comments about that?
Just as soon as I get off mute, I do. Yes, thank you. First of all, that is a phenomenal question, and I have to say that this is such a perfect time to be asking for it. Our new Secretary McDonough, has made this diversity and inclusion a very, very high priority for all of us. And above him, this really comes straight from President Biden, who frequently focuses on equity and so forth. Because after all, in addition to the fact that diversity makes us strong as a nation in just about every possible sphere, the veterans we serve are an increasingly diverse population themselves. So 5 years ago, if you were talking about diversity, or maybe 10, that would have been referring to women veterans. And we are seeing more women veterans, but we're also focusing quite intentionally on serving veterans from multiple backgrounds. So both our Office of Academic Affiliations, which is behind CMS, is one of the major supporters of graduate medical and clinical education, have strong partnerships with the HBCU medical schools, as well as trying to establish affiliations with the minority serving institutions. Complementary to that, our Office of Research and Development is also focused on collaborating with these same institutions for their research scientist training program, because there may be different things that would be appealing. And I can only tell you that our work group in research and development focused on this is, you have to be careful when you ask them a question, because they're so excited about the possibilities. So it feels like a very, very new day at VA for sure. That's
wonderful. Dr. Chen, let's stay on the topic of diverse workforce, and could you reflect on what medical schools can do differently to help ensure a larger and more diverse primary care workforce in the future?
Sure.
Is it happening? What are you seeing?
Well, I think that there's two things that are embedded in there. There's the issue of diversity, which is larger than primary care, but related to primary care. And then there's the issue of primary care. And what I would say is that there's a lot that medical schools and other health profession schools can do in this area. And there are schools that are already doing it. Dr. Clancy mentioned the HBCU medical schools. There are 3 HBCU medical schools. And not only do they focus on recruiting and supporting and graduating excellent Black students, largely because they're historically Black colleges, but they produce a lot of primary care doctors, and they produce a lot of people who practice in rural and underserved. So there are schools that are doing this, but it's not the norm, it's the exception. And we know this. Actually, the U.S. News and World Report just this past March released a new set of rankings, the most diverse medical schools, the medical schools producing the most primary care graduates. I'll tell you, the top medical school, which was Midwestern University, produced 60% who went into primary care. The bottom produced 12%. That's Hopkins. But only 11 of the 159 produced more than 40%. And I use the 40% marker because a lot of people have argued that we need at least 40% of our workforce in primary care. So definitely not the norm. But what could schools do? Schools, I mean, it's about engagement in pathways, in the pipeline programs. It's about who you recruit, what your admission policies are. And once people are inside of medical schools, it's about equity and inclusion, a culture of equity, inclusion, belongingness, which is going to take a lot to change in a lot of our medical schools. But we have to do it. The time is, the demand is there from our students. And then it's about positive primary care experiences. The evidence is all there. It's very clear. It's about changing the incentives. So the incentives, both in terms of funding, but I think in terms of accountability as well, to actually push our medical schools and other health profession schools forward.
And Linda, if I could just add one other comment briefly,
Sure.
Not specific to VA, but since its leader and inspiration, Dr. Cameron Matthews, is at VA, we think of this as part of the fabric now. Before Cameron joined us several years ago, she's now serving as the chief medical officer and was closely involved with this report when serving as a fellow as the Puffer Fellow at the Academy.
Mm-hmm.
She and another colleague started a nonprofit trying to reach minority students at earlier and earlier stages of their careers, encouraging them first to actually imagine the possibility and see people that they could relate to as role models of going into healthcare. Interestingly, they've been going to sort of younger and younger ages. And as you might imagine, as it has happened in so many other areas, the pandemic has been, quote unquote, good for business. They used to have a bus and, physically meet with people in person. Now, of course, it's been Zoom, where like up to 1,000 people are on these calls. But I think that's just one very clear reflection of the kind of outreach we're going to have to do to make this seem like not just compelling, but actually feasible and doable and very rewarding.
Thank you for that. That's an excellent point. And Dr. Troutman, you know that I'm anxious to hear your reflections on the role that educational institutions in nursing are playing to increase diversity in the primary care workforce.
Yes. Well, thank you. I support the comments that my other colleagues have made, and that this is bigger than primary care, but it applies specifically to primary care. What's already been said, we have to address, and schools of nursing are, but to different degrees, access and success. It's not sufficient to have improved admission processes if we aren't assuring the success of students throughout the program. And I'm wearing both hats, AACN and IPEC, so I think some of these comments again extend to all health professions. So I can be multi-personality, if you will. And so I think that access and success is important to all. And then the climate and the culture, it has to change in academia, where we are becoming and need to be increasingly more inclusive. And that is, we learned in the pandemic, for example, some said that previously academia was not perhaps positioned to be nimble. Well, we learned that that's not true, and we have to continue to build upon that. We do need to strengthen, as all of the health professions move forward in competency-based education, it will allow us to more closely individualize educational programs for all students, but certainly supporting a more diverse population. And scholarships, of course, to support the successful ability to meet the financial obligations for programs. And then for all of the schools, for example, in nursing, almost all of the national associations now have as a part of their strategic plan what we as individual associations and a collective need to do to strengthen diversity, equity, and inclusion. All are important, and to challenge ourselves. So that would be a brief response to that.
Linda, just a quick
yes,
point.
Carolyn, go ahead.
Just a quick comment on something that Deb said. I think it's very, very important to change the climate in academic settings. And I just wanted to give people an example. I met with a dean of a brand new medical school a number of years ago. And I was asking, did the school have a niche and so on and so forth? No. They wanted everything from future Nobel Prize winners to quote unquote, the Mother Teresa's who would go into primary care. And I almost burst into tears. This dean was a very nice person, so I held it together. But, if that is our mental model, that's not incredibly compelling. And, as a primary care doc, I've always thought of it as far more compelling than that. And I think that's the sort of message that we need to get across.
If I could add, on the opposite side of the spectrum, when the University of Houston opened their new medical school, their motto was, Houston's health is primary. So they did a couple of things there. They identified a community of commitment, and then they they put in their mission, and when they said primary, they meant primary care, that their commitment to primary care. I mean, holding our schools accountable for things like that is one of the ways that we need to push this forward.
Those are such excellent points. We often, wonder whether we can be all things for everyone, and can schools do an excellent job in all fields. Another thing that we hear frequently is that people come into their educational programs wanting to work in their communities and wanting to deliver primary care. And along the way, and perhaps it's the high student debt that they're carrying, they choose specialty fields or acute care settings for the salary difference. So back to the VA, could you share what the VA is doing to kind of equal out some of the salary differences between primary care and clinicians serving another specialty? Do you use some type of salary incentive to go into primary care? What have you found that works?
So I can't say that we have maxed out on all of our potential strategies. In general, we are trying to hire the very best providers in all areas. And in fact, it goes back to the history 75 years ago of our affiliating with the nation's medical schools, that the then top doctor for the system made the point that we needed to pay people who worked in VA on a comparable basis to their colleagues in the private sector, or we wouldn't have the best clinicians around. There is a market pay component which accounts for cost of living, as well as the unique recruitment and retention needs, for example, for rural areas that are not immediately compelling to as many people. And we're also looking at these same factors, again, recruitment and retention, because as other ways to bring in clinicians. Obviously at VA you have a mission, but we're still kind of sort of tiered, although at a steeper slope with the private sector, but looking for ways, and your report will help to try to figure out, can we be even more imaginative and creative?
That's great. Could the panel reflect on the value of HRSA's loan repayment programs for health core model to incentivize folks to go into rural or underserved areas. Any reflections on that program? We actually recommend in the report that they be expanded. You think that's would help a lot in our country?
Yeah. Could I actually start with, I know that you had asked about the VA and whether the VA was equalizing specialty primary care pay. I don't work for Kaiser Permanente, but as an external observer of Kaiser Permanente and as an observer of teaching health centers that are often graduating people, are trying to put people and trying to put those people into underserved settings, Kaiser Permanente has a bit of a draw for those. That is bad to end up with Kaiser Permanente. But what we watch with Kaiser Permanente is that they've been bringing up their primary care salaries, but they're unable to bring down the specialty salaries. So there remains that gap because they're continuing to compete with their market, right? And when we think about why do people end up or why do people not end up in primary care? Students aren't blind to the fact that there's a wide income gap. And if you're an orthopedic surgeon or if you're an anesthesiologist or any kind of specialist, you're serving, right? You're still practicing medicine. So there's still that mission to serve there. And so there's things that we have to do on the practice side to fix those things. National Health Service Corps is an exceedingly important program in terms of getting people to, at least for a little while, stay in primary care and work in high need, underserved settings. But I also think that National Health Service Corps is a Band-Aid, right? By the time you're at loan repayment, people have made their decisions, right? You're not getting more people into primary care. You miss the opportunity to develop that social mission, that mission to serve underserved communities, right? And so we've seen a large increase in funding for National Health Service Corps through the Rescue Act, an additional $800 million. But we didn't see it in a number of the other HRSA programs that are really aimed at developing the pipeline programs, Health Career Opportunities program, the Centers of Excellence program, the Area Health Education Centers program. When we talk about centering education in communities, those are the programs that are working to do that. But the funding levels for those programs are, I hate to say this, when you compare them to another thing that's incentivizing culture, particularly in medical schools, NIH funding or GME funding, the funding for programs like the primary care training enhancement, which is about $50 million a year, is like a rounding error compared to those. And so the imbalance of the funding, not that we shouldn't fund NIH funding, not that we shouldn't fund cancer research or even GME, but it's just causing this terrible imbalance. And students can see that. Right? Students can see what our schools prioritize. Students can see what practice is incentivizing.
Yeah, and
Linda,
one other point. Sorry, I just want to.
Go ahead, Carolyn.
It's a good thing we're friends. The one other point I wanted to make was getting people to come is one step, right? Providing support for them to be excited about staying is something else. So yes, we have loan repayment and so on and so forth, which helps, although as Candace pointed out quite correctly, that's kind of at one end of the pipeline. But in addition to that, in the past several years, we have developed a rural faculty development initiative. And I just have to tell you, our chief academic officer, when those people are meeting, is completely, totally out of pocket because she's very excited about it, Marge Bowman, as well as the people participating. So when I went to visit one of our pretty rural medical centers that had, I'll just say, some unbelievable challenges a few years back, to see their docs so excited about being part of this was just like, wow. It gives them more of a connection, not just to the mission where they work, but to the overarching mission, which I think that sense of isolation really highlighted this past year for literally everyone, is very important dimension professionally that we can't lose sight of.
Yeah.
Thank
And
you.
actually, Carolyn, that was perfect lead into thank you. What I'd like to add is that, I mean, we recognize that incentives matter, and they're not just financial incentives. When you look at the nurse practitioner data, for example, we know that a significant percent, it's in May of 2021, it was 89% are certified in primary care and 70% are practicing in primary care. And it isn't because they're being paid significantly more, but in fact, for many report, significant satisfaction with their scope of practice, their ability to interact with patients and communities. And so we need to continue to learn more about those incentives. I am not saying that finances are not important. They are extremely important. And I agree with both Candace and Carolyn that we need to continue to provide that financial support, but recognizing that what are these other incentives?
Yes, and training. Nurse practitioner residency programs are starting to, I don't know if I want to say take off, but we're definitely seeing them, particularly in community health centers, recognizing that practicing primary care is I think, and particularly practicing primary care with underserved communities requires additional skills and support.
Mm-hmm. Oh, yes, absolutely.
Right. The panelists are making my job very easy. They're helping me move from one topic to another. And Deb, I'm glad you brought up scope of practice. The committee was asked, what did you say about scope of practice? And as my co-chair so eloquently said, scope of practice issues in the United States are not just a primary care phenomena. Mm-hmm. And the committee really approached it with, of course, these are important. And of course, individuals need to be able to practice at the top of their license. But we are very cognizant of the work that the VA has done in terms of allowing APRNs to work at the top of their license. And could our VA representatives on the call, could you tell us what you're seeing from this change? And are you measuring outcomes to document the effects of increasing the scope of practice of your APRNs in primary care specifically?
Yeah, Dr. Clancy, I can take that one if you'd like.
Yes, perfect.
Yes, and in 2017 is really when the Veterans Health Administration, we implemented the regulatory authority that allowed us to have full practice authority for certain nurses. The 3 APRN roles that we implemented full practice authority were the the certified nurse practitioner, the clinical nurse specialist, and the certified midwife. We did exclude at the end CRNAs from that full practice implementation. The full practice authority within the VA allows the APRNs to practice at the full extent of their education, training, and certification, really without mandatory collaboration from a physician. In order to implement that in the VA, local VA medical centers were required to amend their bylaws that allowed the that assigned the APRNs as LIPs, licensed independent practitioners. And they also had to maintain credentialing and privileging that was consistent with the law. And initially there was moderate uptake, and in September of 2020, the VA required all VA medical centers to implement full practice authority. So I'm proud to say that 100% of all VA medical centers have implemented this full practice authority. I think it was in December of 2020. But preliminary findings, there's a 2021 by Ruggs et al. They published some findings that showed that VA healthcare systems with early adoption of full practice authority showed reduced new patient wait times in primary care, mental health, and specialty care. And there's continued research efforts underway. The Office of Nursing Services in VA is leading that effort, and it's still early, but we really don't expect any reduction in quality measures or patient satisfaction right now.
And Linda, this is Deb. If I could add, Tracy, thank you. I had the privilege of serving on the Special Medical Advisory Committee at the time that this was discussed and implemented at the VA. And I remember very specifically at a meeting complimenting at the time Secretary Shulkin for making this advancement. And he looked at me guardedly and he said, well, you know, Deb, we're not doing them for all four. And I said, yes, I understand. And I wasn't necessarily ecstatic about it, but incremental policy change is important. And a point that he made as a part of what was driving the decision, I will say a part, I recognize that there are others, but was about access. And the VA was very interested in one of its goals. I will simplify it, but was really expanding access to care and being able to demonstrate that, you know, there were improvements. And so I said to him, and I'm sure our colleagues in the nurse anesthetist community will continue to do this, where we have data that we can demonstrate that it will make a difference. I mean, not everything is able to be outcome driven, but it's the outcomes that begin to really drive and then solidify the change. And that's what I'm an optimist, as most people know, and that's what I'm so excited about, Tracy, to see this progress. And then it is my hope and expectation of many that we will be able to demonstrate the value of all advanced practice nurses being able to make these kinds of contributions. But after the meeting, one colleague said to me, well, why didn't you say something? Why weren't you angry about it? It's because we're making progress. I mean, we may not make every change that we want at the moment, but we're moving forward. So I want to thank the VA and commend the VA.
Yeah, and it's an exciting time. So not only did we implement full practice authority for all NPs, we're just recently, over the past year, we received approval to make one practice scope for, I want to say it's maybe between 20 and 30 different professions. And RN is one of them, because there's also different varying practice scopes in states for just a regular RN and their ability to support primary care. So we're very excited about that as well.
We thank you for the VA pushing out models that the rest of the country can see and learn from. And we know you're data driven and that the evidence will be generated, and that's so important. A major piece of the chapter on integrated care teams, patient-centered care, and the workforce focuses on the care is delivered by interprofessional teams. And that's when we were excited to have Deb Trapman here in her role with the Interprofessional Education Collaborative. But we see the models, we know it when we see it, a high functioning interprofessional team. But the real challenge is how do we prepare the workforce of the future to do interprofessional practice? How do we change the way we educate from day one to get students and teams ready for this experience, particularly in primary care, where the competition for rotations in primary care is very acute. And the idea of sending a team of students to learn together is almost impossible. So we're hoping that this esteemed panel has some tidbits of guidance in terms of interprofessional education. How do we know that we are improving the workforce of the future's ability to do this? Deb, Candace?
I can start and then have my colleagues please augment. So from IPEC, as many of you know, the Interprofessional Education Collaborative has grown from 5 to now 21 members. So the good news, we know the competencies are, they're well understood across the country, whether they're well embraced is a different matter, but that people continue to use the interprofessional education competencies in programs. But we know two things I want to say. First of all, we must strengthen interprofessional education in our academic programs, but we have to continue to strengthen interprofessional practice as well. If we train students in great IPE and experiences and environments, and then they enter a workforce that is completely agnostic or hostile to it, that is an effort in vain. If we don't strengthen our educational experiences, then we're in my opinion, and I know my IPEC colleagues, being irresponsible. The pandemic, we saw silos drop. We saw teams come together, embracing the crisis accelerated in some environments. Now, the challenge is going to be to continue that when it's like an ideology, of course, who would not agree with interprofessional education and practice, but agreeing to it and standing it up are very different. And I think, and the IPEC colleagues have talked about, that money, a strong investing in it, having both the structures and the support financially, a strong commitment that has to be at the leadership and every other level in an organization. If it is only at the next to the highest level of leadership in an organization, it doesn't have the same legs as it would in other interests. And then there are, quite frankly, some who are just not interested, but I would suggest they're at the ends of the bell curve, and we'll bring them along later. But I wouldn't spend as much time on the complete naysayers. But we've got to do more that purposely breaks down the silos. And I fundamentally think it's leadership. IPEC has had programming for quite some time now, and it is so exciting. Now every state has had at least a subset of their academic community bring teams to the IPEC programming. We are now just standing up leadership programs because it's going to be important for how we both lead up and lead down. I mean, we've got to be able to garner resources throughout the organization. So those are some of the points that IPEC would make when the teams come together. Some institutions now have had 7, 8 times they brought a team. Those are our, if you will, early adopters way back when, and now continue to be our champions. But it's amazing. We think about with the clinical learning sites. My dream is that we come together and advance these opportunities, because all of us are challenged with finding clinical learning experiences for students. We're becoming increasingly more competitive. And if we can't find a way to be collaborative, I believe that we are doing a disservice to our students and ultimately the population.
Deborah, I'm just going to tag onto that, if you don't mind.
That's great. I was going to call on you, Tracy.
Well, when you talked about, first of all, we educate the professionals in interprofessional practice, but when they enter the workforce and they're not really able to apply that. Well, the VA, as you guys, most of you know, has implemented what we call PACT. It's our brand of patient-centered medical home. And immediately when you come to practice into the VA, your core team is a provider, an RN care manager, an LPN, or a clinical associate health tech type, and then an administrative assistant. And then your extended team members are your clinical pharmacy specialists, your social workers, you have primary care mental health integration. We've integrated our health promotion disease prevention folks, our health behavioral coaches, our veterans health education coordinators. And so automatically you step into a team of interdisciplinary practice. But in addition to that, the VA at the macro level has really made policies that require that training. And we at the Office of Primary Care, we have a section called Clinical Learning, and we deliver our care through the front line through team-based learning. We have asynchronous and synchronous training for the front line, and we're in the process of developing leadership training as a team as well, because what we found in the past is the doc might get trained one way, the nurse might get trained another way, and then the medical support folks are trained, they're all trained differently. But our goal is to have them together kind of as a triad in one training, because it's not just good enough to understand what to do. As leaders, you have to understand how to use the data to make the change and to implement that. But that is, I'm that's one of my, it falls under my lane of effort. So I'm very excited about that. I also wanted to say, when you were talking about interprofessional teams, our extended PAC members, like our clinical pharmacy specialists, really are a force extender, if you will. In the VA, they're not just administering medications at the pharmacy window. They're actually running warfarin clinics. They're conducting population management. And I'll just give you a very quick example. I have an uncle that didn't know that I worked for the VA, that lives in a small rural town in South Carolina. He's a veteran. And out of the blue, a clinical pharmacy specialist called him because of a disease registry that he ended up on, identified that he was 30 pounds overweight, his A1C was 9.1. Through that clinical pharmacy specialist and the RN intervention, he lost 30 pounds, his A1C went down to 7.1. And so really adding those additional team members, like the clinical pharmacy specialists, like the social workers, they're really able to look at social determinants of health and identify those factors that, the social workers, that they can intervene with that team. And the great news is we all are on one electronic health record, so we can all communicate together and make consults within our healthcare organization. I could just go on and on, but I'm going to pause there to see if anybody else would like to add to that. But it's exciting news, Deborah, to hear.
Those are excellent points. And I imagine that we will have some questions from the audience around the whole concept of IPE. The committee took the stance that a primary healthcare team is the core team of clinicians and an extended team. And that extended team, just like the example you just gave, is different in different communities. But what's not different, what should be standardized, are the outcomes that we're trying to measure. And the report has a scorecard that is a start. We didn't want to recreate metrics that are already there, but what we do know is some of the metrics that are used in acute care settings are not the primary metrics that of importance in primary care. And I wondered if you might reflect on, for example, if you look at teaching health centers, they're very accountable. They're the only federally funded physician training program that is accountable for its outcomes. Why's the other $18 billion in funding not measuring outcomes or held accountable? Candace, you look like you're ready to jump in on that one.
And Bob Phillips is also good enough in his.
I want to hear your thoughts about how we know we're succeeding and winning in primary care with valuable metrics.
Right. And I think what you're talking about is particularly accountability around investments in workforce development, and in the case of the teaching health centers, for comparison, the lack of accountability with Medicare GME that puts a lot more money into, it puts the largest explicit amount of money into workforce development, public money into workforce development in the United States to support the training of largely physician residents. And, I think when you look at the Teaching Health Centers program, and if you don't know the Teaching Health Centers program, it was a program that was established in the Affordable Care Act, has been around for about a decade now. And there's some very specific things about the Teaching Health Center program, even before we talk about the reporting requirements. One, they must be in primary care specialties. And the primary care specialties are named: family medicine, general internal medicine, general pediatrics, geriatrics, but also general dentistry, pediatric dentistry, OBGYN psychiatry. Two, the residency program has to be sponsored by the ambulatory primary care site or by a GME consortium that is not the hospital and it's a medical school. Those are two very structural requirements for the program that target the funding to get a very specific outcome. And then on top of it, in legislation, there is annual reporting requirements. Annual reporting requirements that include what are you training, as well as what do they do when they graduate? How many of those graduates go out and practice in underserved settings? And, you know, we say these things, you say that, and you're like, well, you know, obviously we should be collecting that information. But when you go to Medicare GME, the way that Medicare GME and those payments are established in formula, in law, there's no requirements around the specialties that are trained. There's no requirements around reporting. And then the way that the formulas are set up, it effectively ties the funding to hospitals. And so we've basically handed hospitals all of the authority to decide what our workforce is going to look like. And so it's not surprising that we end up with a workforce that's ready to staff the hospitals of America, right? And so to get that change in GME, we need legislative changes. We need, you know, even to just start with measurement, identification and measurement of the important outcomes. What is it that we need from the GME system? And then beyond that, to start to hook those measurements with the payments. The first place we've actually seen that is with the Children's Hospital GME program. In 2013, when they reauthorized that program, they created something called the Quality Bonus System. It was the first effort to identify the critical outcome measures for a GME program and then to link it to payment. We're still waiting to see how that develops out of HRSA, but it's definitely worth watching. And I think it also suggests that there's interest in this. Of course, Children's Hospital GME is funded at about $350 million a year, where Medicare GME is $15 billion a year. So the politics are a little bit different there, but $15 billion of public investment, and we're not getting the workforce that we need. We need, and the National Academies did a great report released in 2014 with incredible thinking. That thinking is still, I think, really strong about what we need to do for Medicare GME reform.
So how do you feel about our discussion today about interprofessional delivery of care, team-based care, integrated care delivery, and so many of these programs largely focused on only one professional component of the team?
Absolutely. I'm so glad that you came back to this, because you're absolutely right. We silo our funding support, and by siloing our funding support, we're creating professional self-interest to protect that funding support for physician residents, for, you know, even inside of those HRSA programs, right, which are, you know, percentage points of what we put into Medicare GME. You honestly start to see a little bit of, you know, this is physician primary care training money, this is nursing money, and while I'm going to say, I think that the HRSA funding, because of the imbalance, needs to be strengthened. As we strengthen it, we could really think about how you bring those programs together to support interprofessional training, to incentivize interprofessional training. I will just share, when I was at HRSA, one of the things that we did is with the primary care training and enhancement, which by statute is focused on physicians and physician assistants. We very much on that idea of you only get enhanced interprofessional education when you address the clinical training environment. We put out an award to say, we want you to enhance your clinical training environments. You can do any number of things to enhance your clinical training environments. And by the way, since we want to see interprofessional training, you can use this funding to not only support the training of physicians, but to support the training of other students in the team. And we got some pushback from the community and I will also say it's important, right? Like when you have so little funding, that these programs are basically holding on by their fingertips, right? In comparison to NIH, you know, like specialty programs that are being supported through NIH funding. But, you know, we create this through our silos of funding. VA actually changed that. VA, their academic offices previously determined how much each of the VAs got based on the number of physician residents training there. And they redid their formula. They redid how they determine the payment to include the wider. So absolutely, VA again stands as an example.
Well, I think that's one of the major recommendations of the report, and it's going to be discussed in more depth in 2 weeks in the implementation webinar. But this discussion about the barriers to breaking down silos and really practicing interprofessional care are real, and having accountability in DHHS to continue thinking about ways that we can break this down and make it more equitable. I want to be respectful for our audience who's been listening throughout all this, but have been sending questions in to Mark. I'd like to take the last 15 minutes of the webinar, Mark, if you want to take over now and ask us the questions that are coming from the audience.
Sure. Thanks, Linda. So we've received a few questions. I thought this one might be a good one to lead with. Can you speak to the power dynamics of implementing these teams? And how do you resolve resistance to them among the clinicians that may be a part of them, but may not be quite on board with the team-based approach?
That's a great question. And
Linda, would you be okay if I made a comment on that? I have it on my list of the chats.
Sure, but also I want to, when we talk about the team, remember that we were talking today, we've given examples of physical therapist, dentist, behavioral health folks, community health workers. So let's take a very broad view of this question. So Brenda?
Great. So that was one of the chats that I wrote down and said, thank you for asking that question. I think what you do with resistance is you prepare for it and you expect it. And so the training doesn't just happen in the educational setting. There's ongoing training that happens when you're changing the practice culture. And part of that training is understanding what everyone's role is and knowledge of each other's roles and when to activate each other and when to actually put that is part of a standard process. So being able to prepare for the resistance, plan for it, then you implement and you say, yes, okay, how do we manage this when it happens? And are all the team roles understood enough so that each team member, whether it's the MA, the pharmacist, the patient, and the family, actually know that what they did to contribute to the team outcome helped reach the outcome. And when you have the silos, it's not clear who's contributing to these outcomes. And it sounds like the VA has done a very good job of actually putting the information and the support teams around it. But having that scorecard and tracking, how well are we performing as a team, requires operational expertise. And I will just comment that on standing it up and sustaining it requires the operational leaders of the practice or of the institution to really monitor and help work through the resistance, because it's going to be there. And as you change it and adapt it for each population and each setting, you have new things to consider and new outcomes to be able to be distributed. Thank you.
Excellent points. Tracy, she referred to the VA. Do you want to say something about that in terms of the power dynamics, how you've changed them in the VA?
Sure, and it is a work in progress, and I agree with you. You have to really understand change management. And to this day, we are having trainings and understanding about role clarification and responsibilities when new folks come in. But for me, as a nurse, coming into the PACT or patient-centered model, trust. It's up to every member of the team to establish trust by doing your job the best you can. And to really, one of the things that we don't do well that we're trying to do better is really measure what it is that I do that has an impact on that patient outcome. I know that, and being able to do that, I think improves trust. But you can definitely see the power dynamics when they're ineffective. I mean, when they're not working or when they're in place, because the outcomes of those teams aren't as good. And you can walk into a clinic and see the team that you know that when you go look at their metrics, they're going to be right, because we look at panel management, continuity, care coordination, and access, and those aren't all measures attributed to the provider. They're attributed to each of the team members. So really, I think you talked about leadership. I think that's so important to get leadership buy-in, because everybody watches the leaders to see how they're supposed to behave at the front line. And if you have, any kind of incongruity within that leadership team, the front line is going to follow suit for sure. But that leadership buy-in, and then really the measurement and showing what those additional team members can do. When you bring your clinical pharmacy specialist online, or when you bring even showing the social determinants of health for the social workers, maybe I'm not taking my medicine, I'm non-compliant with my medicine because I can't afford it, or I can't get a ride to the pharmacy, or whatever that is. And then a social worker can help with that and improve those health outcomes. So, I don't think we'll ever get rid of the power dynamics. I think we just, and sometimes it's different team members. It's not always the provider. We always assume that power dynamic is the provider. It's not always that. But I think that just being open-minded, and I agree with you, leadership, you really have to get that leadership buy-in, or most often the other items won't work. But I'm really pleased in my participation in patient-centered medical home. I think that showing my value to the team and establishing that trust, I think, are some good ways to overcome that. Thank you.
Can I add something?
Yes, please.
Which was, I think, a little bit inspired by you starting us off by saying, don't forget the wider team. And thank the medical assistants, the community health workers, our peer support workers, our social workers. And if I could, and this might be a slightly idealistic approach, but I think that we also have a responsibility of diversity, equity, and inclusion for our workers, for our teams, right? And when you think about medical assistants or direct care workers who are oftentimes paying and going into debt to be able to get a job that might pay you and might even not pay you minimum wage, right? When we start, and then there's all the issues that we have of diversity, equity, and inclusion across the workforce, and so many of these hierarchies are also based on historical, sexism and racism and structural racism. And so there's also this sense of, right now we're in a moment where people are starting to say, what are we doing in terms of DEI in health professions education, in our healthcare organizations? And we have a problem. Honestly, we have a huge problem. And how do we start turning outside and fixing outside things when we have a huge problem inside our house? Right. And so, this might be a moment where we start looking at this issue of DEI in a much more expansive way, not just counting diversity, even though diversity is a reflection of, structural racism and sexism, and a lot of different isms, but also in terms of living wages and supporting the entire team. I think that there might be I hope it's not a moment. I hope it is the start of a major change. And so as we're thinking about DEI, some of the hierarchy is embedded in the issue of, I think, equity and inclusion for our workforce.
That's right. But our trainees and our students, when they are immersed in an integrated care delivery team that works, they know it. They see it immediately. And what's very sad is that I know we graduate people every year, who don't have the privilege of seeing a care delivery team that is really knocking it out of the park. The models are there, and it makes me sad that we can't guarantee that for every student that they'll see
Absolutely. And in fact, what it does is encourage us to not want to do primary care when they, we talk about positive primary care experiences during training, but how many not positive primary care experiences? I watched a video of a student who went to a rural primary care practice for a rotation a couple of years back, and she talked about what a great experience she had, but how hard that rural primary care doctor was working, and how she, was now convinced that she didn't want to do that. Right? You get the flip side, which is when students experience high functioning teams, and then they go out to places that are not high functioning. One of the things that they should do is go, what's wrong with this place?
Right. One thing I would add to Candace and Linda to that point around DEI is that that experience of being in a primary care setting and taking care of under-resourced communities. If you don't have that interprofessional care team, right? The pharmacist, the coach, in my world, the early education specialists, all those people who are so important, a social worker, you're not going to feel good about being able to provide the kind of care that people in low resource communities need, because you cannot do it as a single provider. Right. You have to have a team. And so we want people to feel good about what they can accomplish. These are trainees in under-resourced communities in primary care. We have to be able to provide them with these teams that allow us to provide that kind of care in an equitable way. It's important, I think, for all communities, but I think it is most important and necessary for communities that don't have the additional resources available to them. So that's about making people love primary care when they feel like my team was able to take care of the comprehensive needs that this family had, and recognizing that there are, in many cases, zero other resources that a patient and family might have to provide those comprehensive needs, particularly specifically social needs and the health-related pieces that come with it.
And to be prepared, for the teams to be prepared for understanding, being confident and comfortable dealing with the mental health needs that are normally coming in, the social needs that are coming in, the other needs, the economics of it, being able to be prepared to deal with those issues in life that primary care is exhausted and burdened with every day, that everyone has a part together to begin to start to address the family and the patient as a whole.
Right. And as primarily an educator, I have to say that our acute care settings understand their obligation to train the next generation of the workforce and to provide rotations for trainees. That does not filter down to primary care sites, where many of them are so strapped and so under-resourced, they can't imagine carving out time to train the next generation. And so what the committee hopes is that to look at primary care reform in the United States, that we will change some of the incentives, because primary care providers tell us they would love to take our students, but they can't. They don't have the time to do it. They're working until 9 or 10 o'clock after they go home at night. How could they work with the student? And so these are huge problems that we need to tackle going ahead. And this report is just the start. The webinar today was a chance to really dive into this. It clearly wasn't long enough. I have so many questions that I didn't get to, but I felt like, we talked about some of the large ones with attracting students and trainees to primary care, the financial incentives, outcome measurements, the whole interprofessional education and practice and scope of practice. So big things that we we hope we have opportunities to continue the discussion with each of you in a different context, in a different way, that we can continue the momentum. Anything, Mark, that you want to add to close up the webinar?
No, just that Sarah posted the link in the chat of where to register for our webinar next week and the week after. So the next one is on digital health on June 22nd at 11 a.m. And then on June 29th is the webinar on accountability, also at 11 a.m.
I'm glad you brought up digital health. That was an area, digital health, that's an area that I was going to have questions for the panel, and we didn't get to them. And so I really encourage you to be with us next week to do the deep dive into digital health. Is important not only for access, but also for measuring outcomes and having the data that we need to show the value of primary care. So please think about joining us next week, Tuesday at 11 a.m. And thanks everyone for being with us today.
Thank you all.